Good afternoon, everyone. I'm presenting on topic dopamine, serotonin, and melatonin, and my moderator is my person. Dopamine is one of the biogenic amine neurotransmitter. It is an inhibitory neurotransmitter, and it is a widely distributed catecholamine. It is synthesized from tyrosine. The rate-limiting enzyme is tyrosine hydroxylase, which is converted further into dopa, and dopa is converted into dopamine by dopamine decarboxylase, and dopa is converted into non-epinephrine by dopamine beta hydroxylase, and further non-epinephrine is converted into epinephrine by phenylethanolamine and methyltransferase. Intracellularly, when dopamine is increased, it is destroyed by MAO-A and MAO-B inhibitors. And outside, when dopamine is increased, it is destroyed by catecholamine methyltransferase. And when dopamine is taken inside back into the synapse by dopamine transporter, and it is stored through VMAT. Metabolites of dopamine in the body are 3,4-dihydroxyphenylacetic acid, 3-methoxytyramine, and homovenilic acid. Now the receptors, there are 5 receptors. One is D1-like family, second is D2-like family. The D1 families are D1 and D5, which acts on adenylyl cyclase, and it increases the activity of adenylyl cyclase, and it is located postsynaptically. And the D2 receptor, D2-like families are D2, D3, D4. It inhibits adenylyl cyclase, and they're located on both pre and postsynaptic receptors. And there are autoreceptors that are D2 and D3. Location is presynaptic, terminal, and somatodendritic region. And its activity on the somatodendritic region is negative feedback input. That is, when there is increase in dopamine, it will decrease the activity of dopamine. Now, there are 5 receptors. So different receptors have different function. D1 has voluntary function is in voluntary movement, attention, reward, sleep, impulse control, working memory, and learning. D2 regulates locomotion. D3 main action is in the endocrine function. D4 is in renal function and GI motility. And D5 is in pain process. And now dopamine also acts in the periphery. In the CVS, it acts as a pressure agent, which is used in cardiogenic shock. It acts as a positive chronotropic and inotropic effect. And in the blood vessels, at low dose, it causes vasodilation, and at high dose, it causes vasoconstriction. And in the kidney, it acts at a proximal tubules, and it increases the GFR. Now, there are 5 dopaminergic pathways in the brain. One is nigrostriatal, second one is mesolimbic, third is mesocortical, fourth is tuberoinfundibular, and the fifth is thalamo-dopamine pathway, which helps in sleep and arousal mechanism. The mesolimbic, word, wherever it is, it starts from ventrotegmental area, and it goes to the striatum, that is the nucleus accumbens, and its role is in pleasurable sensation. The drug which we take, the euphoric effect of the drug, as well as in the delusion and hallucinations of psychosis. That is the positive symptoms which is seen in schizophrenia or any kind of psychosis. And the mesocortical pathway, it starts from ventrotegmental areas, and it goes to the prefrontal cortex, that is the dorsolateral prefrontal cortex and ventromedial prefrontal cortex. And the dorsolateral prefrontal cortex, it regulates cognition and executive function, whereas the ventromedial cortex, it acts on the prefrontal cortex. It regulates emotions and the affect. Now, the third one is nigrostriatal pathway. It starts from substantia nigra, and it goes to the striatum, and it is part of extrapyramidal nervous system, and it controls the motor functions and movement. And its deficiencies causes Parkinsonism, akathisia, and dystonia. And fifth one is tuberoinfundibular pathway. It goes from the hypothalamus to the anterior pituitary, and it has inhibitory effect on prolactin levels, just like how an elevated prolactin level causes galacturia. Now, role of dopamine in schizophrenia. When there is increase in dopamine in mesolimbic pathway, it causes positive symptoms, and decrease in dopamine in mesocortical pathway, it causes negative symptoms. Now, what are the drugs which act on dopamine receptors? One is antagonist action, which acts on D2 only, and that is chlorpromazine, haloperidol, trifluperazine, flupentixol, zucropentixol. These has antagonistic actions which acts on D2. And the other second generation antipsychotic which acts on D2, 5-HT2A and 5-HT1A, that is olanzapine, clozapine, which has major actions on, and quetiapine, which has more actions on 5-HT2A, then 5-HT1A, and then D2 receptors. And other drugs are risperidone, paliperidone, which has more action on 5-HT2A, and then D2 receptors and 5-HT1. Now, the role of dopamine in ADHD. Dorsal anterior cingulate cortex, which helps in selective attention. Dorsolateral prefrontal cortex, which helps in sustained attention, problem solving. Prefrontal cortex, which has in hyperactive symptoms, and orbitofrontal cortex in impulsive symptoms. So the faulty tuning between dopamine and non-epinephrine in prefrontal cortex, and the receptors involved are D1 receptors. And depending on the relative levels of both dopamine and non-epinephrine, a person would show symptoms of ADHD. And now the drugs which are used in ADHD are methylphenidate, amphetamine, and atomoxetine. Now, second one is Tourette syndrome. This is a hyperdopaminergic condition, and this occurs due to supersensitive of dopamine receptors, which acts on presynaptic dysfunction in dopamine neuron. Treatment is tetrabenazine and antipsychotic. Third one is dopamine in substance abuse, that is from mesolimbic pathway to ventrotegmental area. The different drugs have different reward values. That is, dopamine is associated with motivation. And when there is substance consumption, it increases the dopamine level in mesolimbic pathway. Fourth one is dopamine and Parkinson's disease. There is degeneration of dopaminergic neurons in basal ganglia. Pathways involved with nigrostriatal pathway. And there is a reduction in inhibitory neurotransmitter, which causes increase in muscle tone. And there is tremors, rigidity, bradykinesia. And the drugs which acts on, which we can give a dopamine precursor, that is levodopa. Peripheral decarboxylase inhibitors, that is okay. Then dopamine in sleep and arousal, and in restless leg syndrome. Due to deficiency of dopamine receptors, there is reduced modulation of sensory, motor, and autonomic systems in spinal cord. Second one is serotonin. Serotonin is a monoamine neurotransmitter which is synthesized from tryptophan, and 80% are found in GIT. It is synthesized from tryptophan, which is then converted into 5-hydroxytryptophan, and then through aromatic amino acid decarboxylate, it is converted into serotonin, and then serotonin is further converted into 5-hydroxy-indole acetic acid. Here, serotonin, same way, we can see that it is converted from tryptophan. It is converted by the enzyme tryptophan hydroxylase into 5-hydroxytryptophan, which is then converted by the enzyme aromatic amino acid decarboxylate, and it is then taken up into synaptic vesicles via vesicular monoamine transporter. The termination action, there we had seen that intracellularly in dopamine, monoamine A and B both are responsible for destruction of dopamine. But here in serotonin, monoamine B destroys when there is increase in serotonin. And in extracellularly, there we had seen COMT is responsible for destruction. Here, MAO A or MAO B destroys the extra serotonin, which is present extracellularly. Now, classification of receptors, presynaptic and postsynaptic. Presynaptic receptors are 5-HT1A, 1D. They are autoreceptors, and they are present on both somatodendritic and terminals. And the postsynaptics are 5-HT1A, 1D, 2A, and 2C, 5-HT3, and 5-HT4. Now, the drugs classes, the names and the effects on 5-HT. Atypical antipsychotics, which are like clozapine, risperidone, they act on 5-HT2A antagonist, and anxiolytics are buspirone, which has 5-HT1A partial agonist action. SSRIs, which is a SERT blocker, SNRIs, again, SERT blockers, and non-adrenergic and specific serotonin, that is metazapine, which acts on 5-HT and 5-HT3 antagonists. The other drug is serotonin 1A agonist, which acts as a SERT blocker and 5-HT1A partial agonist. MAO inhibitors are non-selective and which are isocarboxyl, which acts on effectors. It is a MAO inhibitors. Others are TCAs, antiemetics, triptans, antihistaminics. These all have actions on selective 5-HT receptors. Now, the functions of serotonin in frontal cortex, it regulates mood. In basal ganglia, especially 5-HT2A receptors, it controls movement, obsession, and compulsion. In the limbic area, especially 5-HT2A, 2C, it acts on postsynaptic receptors, which is involved in anxiety and panic attack. Hypothalamus, especially 5-HT3 receptors, which regulates appetite and eating disorders. Now, in brainstem sleep centers, especially on 5-HT2A postsynaptic receptors, it regulates sleep. And in brainstem chemoreceptor trigger zone, especially via 5-HT3 receptors, which induces vomiting. And periphery, it affects is on GIT, smooth muscles, blood vessels, nerve ending, glands, or CVS, it has positive inotropic and chronotropic. Now, there is serotonin syndrome. It is a serious drug reaction. When we give too much serotonin, it has signs and symptoms which can range from mild to severe. Mild will include shivering and diarrhea. To severe, that is muscle rigidity, fever, and seizures. And it can even cause death. It occurs when we increase the dose of certain medication or a new drug is introduced. And when we give migraine medication and an antidepressant, it is a potential life-threatening syndrome. And signs and symptoms are like agitation, insomnia, confusion, rapid heart rate, increase in blood pressure, loss of muscle coordination, muscle rigidity, diarrhea, sweating. And signs include high fever, tremor, seizures, unconsciousness. Treatment is we remove the offending agent, and we give a supportive care with nitroglycerin or cyproheptadine, or we give a benzodiazepine or an anticonvulsant. Next is melatonin. It is secreted from serotonin by aryl alkylamine N-acetyltransferase, and it is converted into N-acetyl serotonin, which is then further converted into melatonin by acetyl serotonin O-methyltransferase. It is produced by pineal gland, and maximum is located in the gut, which is in the endochromatin cells. And the site of metabolism is in the liver, and it is first hydroxylated, and then it is excreted in urine as sulfate and glucuronide conjugates. Now, the doses in India, it is present as oral tablets and in syrups. Usually, the one in elderly, we give in syrup in dose of 3 mg per ml or 6 mg per 10 ml solution. And it is also available as oral spray. And no dosing adjustment is needed in renal impairment. And it is contraindicated. It is not given in pregnancy, but it is safe during lactation. And in short, its mechanism is here. CNS, it acts as a in circadian rhythm modulation, sleep-wake disorder, sleep disturbance, and in cardiovascular system, it is used in hypercholesterolemia, hypertension. In reproductive symptoms, preeclampsia, fertility. In GI, in GRD, ulcers and irritable bowel syndrome. And in immune system, in autoimmune condition. And in musculoskeletal system, in osteopenia. Melatonin level, it peaks during mid sleep cycle, and its level declines during daytime. And a newborn produces minimum melatonin, and in elderly also it produces negligible amount of melatonin, and it is maximum amount is occurs during puberty. These are my references.